doing that I'm going to talk about today. And I was really sorry to miss my friend Pilar Chiavo, who I know spoke earlier. And I mean, just think of it, how incredible it is that a labor Democrat who doesn't modify her position, who supports universal health care and takes on the tough issues, takes out an incumbent conservative in that district. It's extraordinary what she does. Do you ever want to know what it takes to get elected? Be like Pilar and work your ass off. That's what it takes. So I'm so glad that she got to speak to you all today. So we got a situation I think all of us are familiar with, because ultimately healthcare is a public policy issue that is so personal to us every day. Our families, how we bargain, well, really just, it's essentially, it's not an exaggeration, a life and death issue. And so it's a matter of public policy that affects us deeply. And the situation in California is very mixed. In some ways, very difficult. I mean, half of us who live in California last year didn't get some treatment because it cost too much. Think of that, half the people in the state didn't get something they needed because they simply couldn't afford it. And then we also know that when we need care, we feel the impact. Well, maybe it's a high out-of-pocket, payment we got to make. Maybe it's a deductible that we got to meet. And these increasing costs, maybe even the health plan doesn't approve a prescription or a doctor order or other treatment. Right? We're almost at the mercy of these health plans. Maybe we even have trouble getting a doctor. Certainly there's often this talk about, you go to a kind of Medicare for all type system, you're going to wait in line. Well, how easy is it to get a specialist appointment? Not so fast usually, right? And so it was also clear during the pandemic that the mental health crisis created this huge need for services that just weren't there, that health plans don't cover in many cases. So and that's really something essential to the union that I consult for, National Union of Healthcare Workers, that represents all these mental health professionals. And they're in the front lines of trying to deal with the crisis that they simply don't have the staffing and resources to do. So one of the ways that we try to understand this system is we supported the Healthy California for All Commission, which issued a report. And it describes the wasteful, fragmented healthcare system, which is a big deal. You get an official report, appointed by the legislature and the governor, that basically says, hey, there's all this profit making in the system and people aren't getting the care you need. And the huge disparities that especially affect low income and communities of color. Nearly 90% of Black, Brown, Asian Americans in California experience discrimination and disregard when they try to get health care. I mean, that's really, it's quite something if you think about it. Like, that's just the universal experience for many of ourselves and our friends and colleagues. And perhaps most striking about that commission work was it showed that if we just keep the system as it is, we're going to spend another $500 billion in 10 years. Think of that, $500 billion in 10 years if the system stays as it is. And that means nothing changes. No improvements in coverage. Continuing cost shifting. The boss is still going to be coming after us, right? Every time the premiums go up, they're going to try to take it out of our pocket. Now the deductibles are going to go up. All that's still going to happen. Mental health coverage will still be tough to get, but we'll pay an extra $500 billion for the privilege. It's quite something, but it's particularly affecting all of you, and I don't need to tell you about this, the double-digit premium increases, the cost shifting. I mean, let's face it, every dollar that we bargain into healthcare is a dollar out of our pocket. It's a dollar out of our wages. Every single one of them. It's basically just a cost shift. Okay, we'll pay the boss who then pays the insurance plan. Right? And the fight is just to maintain what we have in many cases. So what we want to do is we want to essentially take healthcare off the bargaining table so we can raise wages and pensions. That's really it, simply put. When we talk about this system, we talk about single payer, in contrast, really basically the current system we've got, one might say, is like a system of graft and corruption that we pay for. And what we're going to do instead is guarantee health care to all residents of California, make care accessible, affordable, equitable, high quality, and universal. We call it single payer because it means that one public source pays for health services. And it turns out individuals, businesses, government saves literally billions of dollars. I'm getting excited, I can't help it. Okay. And so this is what the Healthy California Now coalition is about. And you all are an essential part of that coalition. It's 45 organizations. We got a number of unions involved. But the question is, okay, we've got this compelling argument, right? We know what the system is like. We know what the system is like. We know the problems with it. We know there's a moral imperative to change it. But how do we do it politically? Because we keep going to the legislature and say, hey, pass this big bill. Pass the single payer bill. And it hasn't worked. And some of us have been doing it for 30 years. And some of us had more hair, and it wasn't gray when we started. But here we are, right? Needing a haircut and still trying, okay? So the thing is that we needed an alternative path, and that's what SB 770 is designed to do. It's a way to get folks together, and particularly to get unions in the room, figure out what kind of system's actually going to work for us, and talk to the feds, who ultimately are going to have to provide about half the money if we're going to finance it, and figure out what they'll approve as a new system. And then once we know that, go back to the legislature and say, hey, here's what we know. We got all these key issues figured out. So pass a bill that addresses those, and we'll get the federal money, and we'll be able to guarantee health care for all Californians. That's essentially what SB 770 does. Because, frankly, unless we really build this broad movement, get unions at the forefront of it in California, it's not going to happen. So it's a very pragmatic approach. So what I have up here on the screen is a calculator. Because not only will we save hundreds of billions of dollars for California in general, but individuals will save literally thousands of dollars. So you can go to healthycalifornia.org /calculator, and you'll find there that you can figure out what you currently spend. You can put in what you currently spend, and then calculate what you would spend under a new system. So it would be what we call, first you decide, okay, do we have Medicaid? No. Do you have health insurance last year? Yes. Is it family or single? All right, let's say family. And then it's got preset numbers in there, right? Boom, boom, boom. And if you know your specific number, you can put it in, but you don't have to, because we've got average numbers that go in there. Oh, I did pretty well, I guess. I just used the average numbers and saved $18,400. Oh, okay. That's not bad.
Wow.
But people on Medicare who do the calculator on average save $5,500. So tell me, in this inflationary environment, where are you going to put $5,000, $9,000, let alone $18,000 in your pocket? It's really quite extraordinary. And so you wonder, well, God, why hasn't this happened? Well, it hasn't happened because there are very deep pocket interests who, when you take out their profits and you control prescription drug prices and you set rates for hospitals and doctors, they don't do so well. And those same interests were the ones who funded a multi-million-dollar campaign against Pilar Chiava. So it is all connected, and that's why we're here. And I'll tell you, what we have found is that even though we have this compelling case, even though we know it's the right thing to do, and it works everywhere else in the world, basically, of a similar country, we haven't gotten the political will, and we haven't built the political coalition to succeed. And when we do that, we will win. And that's what SB 770 is setting up. That's what Healthy California Now is doing. And that's what the participation of California Conference of Machinists is making possible. So thank you very much. I'm happy to answer any questions.
Yeah, so given thought, the coalition given thought to maybe looking at it a little more incrementally, meaning, for instance, like Medicare was achieved 60 years ago, and at the time it was, it was very controversial. If you ever heard the Ronald Reagan speech where he said that, someday your grandkids will ask what freedom was like, living in a free country, it was like communism and all this other stuff, and now Medicare is the most popular program the government has, right? And Medicaid, that's even Kevin McCarthy doesn't want to touch Medicaid. So does I don't know why nobody thought of this before. I can't be the only person that thought of this. Why not break it into pieces and put kids on Medicaid? When you have a kid, right, they get a Social Security number within now, like a week or 2 weeks or something like that. They get a Medicare card. They get, you have to pay something for it. I mean, imagine when you're sitting there and bargaining, at least in California, a family health plan somewhere between, depending on how good it is, $1,500 to $2,200, depending on what you're looking at. You go down to a two-party health plan, you're $1,000, right? So covering a kid or a kid is hundreds and hundreds of dollars a month. If you have that money freed up, back at the table for retirement wages, whatever, it's not going to run. Kids are the cheapest to cover. I mean, you got 100 kids in a room and 100 old people. Who's going to rack up the big bills?
Well, you're exactly right. And this was a proposal that was in Congress for decades, called the Kennedy-Dingell bill. And it literally, by age group, expanded Medicare. So that you took people exactly as you say, under 18 and over 55. And then you would just basically get the rest of the middle over, some period of time, 5-10 years. I mean, the problem, of course, is that the same arguments that are used against it, even though it's incremental, right, are used against the whole thing. But, so we're thinking, well,
kids are cheap. Right?
Kids are cheap, exactly. And in California, those kids that are particularly, vulnerable are in Medi-Cal. Right. So they're right. So but Medi-Cal's got real problems in terms of provider rates, access, and so forth. So what we want to do is say, well, no, we're going to bring them into this new system, along with everybody else. And it may be that it's going to depend on what the feds approve, right? So this may end up being an incremental process, just de facto, just because that's the way it turns out. But we think it's smarter to try to figure out, okay, what are all the issues, what are all the problems, and then address them before the legislature is asked to swallow the thing whole. So yeah, I mean, I totally agree with you. That would be the smart way to go. And in DC, I don't know that, kind of the smart way to go. It doesn't seem that that likely these days, I'm afraid.
Thanks, Mike. The majority of my contracts are in the service contract arena. So we have a lot of members in our district that are in the service contract. If they enjoy health and welfare benefit that they get from the area wage determination. So, and it's negotiable, right? So we have contracts that have $4.80 an hour all the way up to one of our other contracts from before that's $15 an hour for their health and welfare. We also negotiate the language in there because a lot of our members in the service contract are ex-military. They have TRICARE. So we have negotiated some where we can negotiate for them to opt out or cash in lieu if they don't use them for part of their wages, right? Would this negatively impact them if we go to one and that health and welfare benefit goes away?
Well, I think that is kind of an open question, to be honest with you. But secondly, the federal government, which has to approve California's program, is very unlikely to mess with TRICARE. We know they're not going to mess with the Veterans Administration. That's off the table, not going to be part of what we do in California. TRICARE, you could imagine a way it could be integrated, and you can imagine a way that it's separate. And I think it's going to really depend upon what the federal government wants to do. But if it turned out that we had an understanding, like you just laid out, that it's going to be disadvantageous, right, to workers or to folks who are in TRICARE now, to include it, then that would be a huge factor against us trying to.
Yeah, just looking at options of putting guardrails around that to protect them, because it's not messing with TRICARE, but it's messing with the opt-out language that we have for cash and lieu. If they're not using that health and welfare, to apply it to their wages.
Right.
And that's how we organize. We use that as an organizing tool to let them know when they see a contract down the street where they're getting health and welfare benefit, that they can opt out and use that money to put in their wages and supplement their wages. They organize.
Right.
They organize. And this is besides the question, because I think this is a great deal of single employer plan for medical for all. But just looking at this version here, would may affect our people that are serving in the SCA role.
Right, exactly. I mean, the principle that we're trying to apply to everybody is the same one, right? Is in lieu of paying all this money to healthcare, raise your wages. That's what we're trying to achieve. If it turns out we can achieve that by including them, right? And so that benefit wouldn't be specific to them, but would be still the same, but everyone would benefit. That's another way to go. In terms of organizing, I think that we can also make the case that, hey, under the system, we're going to demand higher wages based on lower healthcare costs, and we're going to demand pensions at a better rate. And so we can take those same incentives to be in a union, right, and shift them to those other benefits, particularly pensions, I think, and wages. But that's why we need the unions at the table as we design the system. So we don't just say one size fits all here, legislature pass a big bill. No, you're gonna have to actually negotiate the differences and the nuances of how it affects particular workforces.
Thank you.
You said similar countries had adopted this healthcare program. Which are these countries?
Well, basically every other industrialized country in the world has some version of it. There's a Canadian version, which they call Canadian Medicare. There's the National Health Service in the UK. There's a system in Germany based on sickness funds. But the similarity, Australia, France, the similarity all of them have is that there's a single public source of funding. And then how they do that, how they complement that with different elements, right? Supplemental benefits, what's the administrator of the benefits, that varies. But the principle that you have one common set of benefits and you have one single source for payment of what's covered, that is in common.
Second part of the question is, will it affect our treatment plan? If going low cost, since everything is going in the other direction and we bring the cost down, how would we bring it down?
How would we what?
How would bring the cost down to pay, but everything else is, the cost of a surgery is going up?
Right. Well, that's why you have a setup so that you're actually negotiating and setting rates for providers and hospitals. Or you give hospitals a budget. Say, okay, well, last year you spent $5 million taking care of your patients. We'll give you an inflation increase, $5.5 million, and you'll take care of your patients, based on that budget. But that doesn't mean that they can go up to $6 million or $6.5 million, right? You set a limit as to what monies they're going to get from the system. And then we estimate, and the commission did too, that I mentioned, the Healthy California for All Commission, that you could cut prescription drug prices in half. Well, once you do that, right, you've got a lot of money to be able to either provide better benefits or lower costs. And so that's what we don't have in the system. The insurance companies can charge whatever they want. The drug companies can charge whatever they want. The hospitals charge whatever they want. There is literally no cost control in the system. And so what we do, once we have a single source of payment, guess what? You got leverage to lower costs.
The other thing that's sort of added into this mix, the insurance companies do not provide care, okay? The money gets funneled through them, they take their cut, they've got their profit margin, but not a dime of that money that goes through the insurance companies provides a modicum of care. So if we're cutting them out of the picture and their profit margins that aren't providing care to patients, we're going to save a shit ton of money and we're going to get better care.
Here. Exactly. I mean, come on, they're taking 30% off the top. I think that's better than the mob. I mean, these
They are
guys.
the mob.
They are the mob, exactly. Well, yeah, no, they're based upon the actual cost of the present system versus what would happen if you had the cost controls I talked about and you lowered prescription drug prices, you eliminated the profits of the insurers and all the administrative waste that they cause. So that's what it's based on. Okay, how are we going to, we're going to eliminate waste, we're going to eliminate profits, we're going to lower drug prices, and we're going to set rates. So that's where the cost savings come from. No. But what they're going to get is they're going to get the money that they need to cover the patients and the salaries of the healthcare workers. They're not going to get extra money for, profits, for high executive salaries, and they're not going to get money for like their capital projects, right, which they use to buy other health systems or build facilities that we may not need. Right? It's going to be actually based upon what does the community need, right, for facilities, and what do we need for services. Well, we're expecting that to be covered, frankly. We're expecting dental to be covered, hearing and vision to be covered. So even people who are on Medicare will get the supplemental benefits provided through the state program. But on the other hand, there may be other supplemental benefits that trust funds can still negotiate. And that mix, again, is why we gotta have unions at the table to figure out where that mix is. But the really amazing thing is that we can take the savings generated by the system and guarantee long-term care to everybody. I mean, who can afford long-term care now? I mean, my father-in-law is in home, right, hospice at home, 120 grand a year. Who can afford that? And so what this system does, because it saves so much money, is we can guarantee universal long-term care in a nursing home, at home, in the community.
Another question. If this plan does not work, is there any way we can go after those insurance company to ensure that, that they're charging us the right cost to, is there any other way?
Well, I mean, is there any other way before we get a full-blown change to go after them? Well, we are the state set up this Office of Healthcare Affordability.
Yes.
And so it is trying to set up a system like what I'm talking about here, where you start lowering rates, right? Actually setting rates, and then you figure, well, okay, if the hospitals can't charge so much, then the insurance premiums won't go up because they don't have to pay for higher hospital costs. So that's going on, right? That's a good interim solution. We're talking about the state of California producing insulin. Well, that would be a lot cheaper, right, than what it currently costs. So if insulin costs are driving up insurance costs, well, that'll help. And so we can do those kinds of things. But to achieve the real savings that we're talking about here, right, in terms of getting rid of profits, getting rid of all the administrative bureaucracy, it's going to take a system change.
So does that get rid of the cost that has down to, for example, there will be no cost at all and there will be no copay?
That's right. There will be no co-pays, no premiums, no deductibles. But that's why what the calculator shows you is, you're going to have to pay some taxes. But the taxes are far less than what you're currently paying in most cases.
So is the tax based on the individual? or-
Yes.
Oh,
It'd be, I mean, there are different versions of it, right? There's an employer tax, income tax, so it depends on what mix you choose, right? But the individual cost is instead, instead of paying your insurance premium or paying the out-of-pocket cost, you haven't made your deductible or your, $20 office visit pay, that is gone, all that's gone. And instead, you've paid a tax.
but we don't know what that amount is.
Well, that's what the
How
calc.
do you kind of negotiate that?
That we do ultimately have, the legislature has to decide that tax. But that's what the calculator is showing, is that, hey, here's a progressive way to raise that money, and it turns out to be substantially less expensive for individuals. Even for employers, employers are paying what, like 20% of payroll, a lot of times for healthcare, cuts it in half. Even when they have to pay a tax.
Isn't it sort of a single payer already for the uninsured at the hospitals? Aren't we paying that as taxpayers?
Well, yes, that's why it's not a good deal.
Right.
Because the hospitals are still charging whatever they want.
But they talk about us paying how much, the negatives, but we're already paying that for people that are underinsured and uninsured.
Yes, we are.
And where's
Yes, we are.
is that that needs to be
No,
part
that's
of
part of
it.
that.
Is
That's in the
part in
mix.
there?
But
Okay.
that's right. We're